Thanks, Dr. Guan, for that introduction. My name is Alec, PGY4 here at the Department of Urologic Sciences, and today I'm going to be talking about immune tolerance. I want to thank Dr. Lan of Nephrology for his assistance on this project. So here's a brief outline of what we'll cover. I want to start and frame the problem, cover some immune system basics and immunosuppression regimens, then discuss what exactly is immune tolerance, as well as some of the main protocols that are being utilized, and then possibly touch on some future directions, maybe some future UBC directions. So let's frame the problem. As we're all aware, end-stage renal disease in Canada is increasing. Close to 50,000 Canadians are being treated for renal failure. 62% are receiving dialysis, and 38% have a functioning kidney graft. This represents a 17% increase in patients receiving renal replacement therapy since 2013. However, things are not all bad. Over that same time period, the median wait time for deceased donor kidney transplants has improved by 17%, from 4.1 to 3.5 years. Although continuous improvements have occurred in dialysis, the 5-year mortality of hemodialysis patients is shockingly high at 50%. Furthermore, Cato in 2018 showed that quality of life for patients on dialysis is often lower than patients with significant chronic diseases, such as cystic fibrosis, sickle cell anemia, as well as some forms of cancer. As we know, and has been discussed in grand rounds many times in the past, transplant improves mortality amongst end-stage renal disease patients. Davide just this year showed some data estimating that it prolonged patient life up to 10 years. And in a study from Caballo, they demonstrated that 5-year mortality was increased by 47%, and quality of life drastically improves after the initial perioperative period. Renal transplant is obviously the gold standard for end-stage renal disease. But is transplant as it exists today enough? Can it be improved upon? As we know, grafts don't last forever. And as we can see here, around the 5-year mark is when grafts drastically begin failing. Now, it's important to note that failure in this graft can be for a lot of reasons: patient death, infection, recurrent renal disease, chronic rejection. But the current immunosuppression medications that we use compound all of these issues. And this is where transplant tolerance can come into play. But first, let's discuss immune suppression. But first, before we discuss immune suppression and tolerance, let's talk basic immunology. So when a graft is placed into a recipient, the recipient's immune system forms a response. This is termed alloimmune response, which is initiated by T-cell recognition of alloantigens, commonly known as allorecognition. The MHC, or the major histocompatibility complex, on human chromosome 6 encodes for the HLA antigen, which is the most important alloantigen recognition system. HLA molecules are glycoproteins in nature that act as receptors on the cell surface of antigen-presenting cells. They bind antigens and then present these T cells so that the body can respond appropriately. Thus, they play a vital role in immune recognition, including the interaction between T cells and other cell types. Significant heterogeneity exists in MHC loci across populations, and this presents a challenge in transplantation. There are 2 types of MHCs expressed in humans. MHC class 1 consists of 2 chains, an alpha and a beta chain, and they are covalently connected. The alpha chain encodes 3 essential MHC molecules: HLA A, B, and C. MHC class 1 molecules are present on any nucleated cell throughout the body and function to present antigens to CD8 positive killer T cells. MHC class 2 consists of, again, 2 chains, but each chain consists of 2 domains, making MHC2 a heterodimer. MHC2 encodes HLA-D, which is further broken down into 3 essential HLAs, HLA-DR, DQ, and DP. MHC2 is only found on cells of the immune system, macrophages, dendritic cells, B cells, and it presents antigens to CD4 T-positive helper cells. We know that HLA are the essential transplant antigen, and we can see how HLA inheritance follows a Mendelian codominant pattern. Each parent provides a haplotype to each offspring. Class 1 molecules, HLA A, B, and C, and Class 2 molecules, DP, DQ, and DR, are inherited in this Mendelian fashion. As you can see with sibling donors, you have a 25% chance of an HLA identical match, a 50% chance of having haploidentical, or a 25% chance of having no match. And when we look at HLA matching and transplantation, we know that the degree of HLA mismatch between the donor and the recipient plays a key role in determining the risk of chronic rejection and graft loss. And this is something we can exploit in donor-recipient pairs. As you can see from this study from Havid's, there's almost a dose response in the number on the number of HLA loci mismatch and graft survival. Traditionally, HLA A, B, and DR were looked at for HLA matching, but increasingly centers are looking at all 6 antigens to match in living donors. As we know, the best graft survival comes from identical HLA matches. But as you can see, even in this data, in HLA identical grafts, graft survival is obviously not 100%. Part of that is that mismatch occurs at non-HLA sites, but part of that is also due to the medications we use to control early graft rejection. So let's talk immunosuppression. Most immunosuppression regimens follow this general layout. There's induction medications, often basiliximab with steroids, or rapid ATG with steroids. And as residents, we know that BASI is used in instances of low immunologic risk and rapid ATG in instances of high immunologic risk, to simplify things. Next, maintenance immunosuppression is used. This consists of steroids, either low dose and daily, or high dose with a rapid taper, an antimetabolite, which is often mycophenolate mofetil, and a calcineurin inhibitor, either TAC or cyclosporin. The optimal immunosuppression regimen maintains graft function while minimizing rejection and limiting potential for adverse effects. And the exact regimen really depends on the center's expertise and the patient's specific immunologic risk. In 1949, corticosteroids were shown to have therapeutic efficacy in rheumatoid arthritis. They were found to have immunosuppressive activity, and this has been exploited in organ transplant since. Corticosteroids are used for immune induction and maintenance for 2 main effects, in addition to many others. First, corticosteroids alter the distribution of circulating lymphocytes. This causes sequestering of CD4 positive T cells in the reticuloendothelial system, in essence causing lymphocyte depletion. And second, they're hydrophobic and can easily diffuse into cells and bind to cytoplasmic receptors. This allows them to enter the nucleus and bind to GREs, which reduce nuclear factor kappa beta, which causes overall inhibition of cytokine transcription. The combination of these cellular effects is such that steroids reduce both IL-1 and IL-6. And these are key interleukins in the maturation of T and B cells, which allows glucocorticoids to impact both humoral and cellular immune systems. And then, as I mentioned, above and beyond these 2 known and well-studied effects, it's known but not fully understood that corticosteroids have a wide range of other immunologic impacts. Antimetabolites are the next mainstay in immune suppression. And for our purposes, we'll focus in discussing MMF, as this is the most commonly used antimetabolite transplant immune suppression regimens. Mycophenolate mofetil is a prodrug of mycophenolic acid, and mycophenolic acid acts as a strong inhibitor of this molecule, inosine 5 monophosphate dehydrogenase, or IMPDH. This causes depletion of purine nucleotides, preferentially in T and B lymphocytes, and therefore inhibits their proliferation. This, in essence, suppresses cell-mediated immune responses and antibody formation. The last pillar in transplant immune suppression regimens are calcineurin inhibitors, and this means tacrolimus or cyclosporin. In Davide's grand rounds this last fall, he compared the 2 in depth to show why we typically use TAC versus cyclosporin. And it's beyond the scope of this talk to dive into that further, so I'll just focus on TAC. TAC is a macrolide produced by the fungus Streptomyces and acts to inhibit T cell proliferation by binding FK binding protein. The resulting complex then binds to calcineurin, which prevents dephosphorylation of the cytoplasmic component of the nuclear factor of activated T cells. This blocks the transport of these nuclear factor activated T cells into the nucleus, therefore preventing their binding to nuclear promoters of the interleukin-2 gene. Consequently, T cells do not produce IL-2, which is necessary for full T cell activation. Therefore, TAC blocks proper T cell functioning. So as I've alluded to, many issues occur from immunosuppression. For each drug, you can see a laundry list of concerns, and I'm just going to highlight a few. One of the primary concerns with corticosteroids is due to increased cardiovascular risk that transplant patients incur with long-term use, as CVD-related death is the #1 cause of known death in patients post-renal transplant. This accounts for 1/4 of total deaths. MMF is mainly associated with gastrointestinal effects, and calcineurin inhibitors cause many long-term issues, namely long-term graft failure through nephrotoxicity, but also they can induce diabetes and neurologic complications. In addition to these risks with clearly defined pathologies, it's well known as well that patients post-organ transplant are at an estimated 3 to 5 times greater risk of increased malignancy in comparison to the general population, with non-Hodgkin lymphoma and non-melanoma skin cancer carrying the highest burden. It's also worth mentioning that for patients who are lower immunologic risk, we do remove steroids, and there is work being done into reducing calcineurin inhibitor trough levels and following graft function thereafter. Moving on, though, we know that end-stage renal disease is a huge problem, and it's only increasing. And we know that renal transplant is the solution. But how do we prolong graft survival? Current immunotherapy is excellent, but can we do more? Can we reduce patients' immunosuppression or get them off it entirely? And that's where tolerance comes in. Tolerance was thought to be possible the holy grail of transplantation. We have an immune system, and for the last 60 years, we've used suppression to allow organ transplantation to exist. But as we move forward with increased clinical precision, we move into talking about immune regulation. First, let's talk about a quick case. This is a case shared by Dr. Lan of Mr. DZ. He was, at the time of consultation, a 37-year-old seen in Dr. Lan's transplant clinic. He was being seen for a history of recurrent AKIs. He had a medical history significant for previous pediatric transplant for renal disease secondary to nephrotic syndrome in 1990, and he was seen in 2017. As well as hypertension and hypothyroid disease. At the time of consultation, he'd had those few AKIs that were quite significant, one requiring continuous renal replacement therapy, both occurring in the setting of sepsis. Renal function after both episodes had recovered to his baseline. And here's a complete list of the patient's medications that he was on at the time of consultation. What do you notice about these meds? Well, the patient was not on any immunosuppression. He had a well-functioning kidney graft, but for the 16 years prior to seeing Dr. Lan, he had not taken any immunosuppression medications. Dr. Lan actually sought out the donor HLA typing from this patient's transplant, and it showed that Mr. DZ was very well matched to his donor. In fact, Dr. Lan had done anti-HLA antibody testing, and Mr. DZ did not have any anti-HLA antibodies to his donor graft. The patient had even undergone 2 renal biopsies during the interval off immune suppression, which showed no evidence of rejection. How is this possible? Well, Mr. DZ had become tolerant to his kidney transplant. Self-tolerance is the process by which immune cells are made unresponsive to self-antigens. Breakdown in self-tolerance leads to autoimmune disease, and malignantly induced tolerance has actually been shown to play a role in specific cancers. Tolerance is broken into central and peripheral tolerance, and it works through 3 main mechanisms, in addition to many others. Principal mechanisms are apoptotic cell death, called clonal deletion, functional inactivation without cell death, called clonal anergy, and suppression of lymphocyte activation and effector functions by regulatory lymphocytes. Central tolerance occurs mainly through clonal deletion, whereas all 3 mechanisms contribute to peripheral tolerance. Central tolerance occurs during the maturation of lymphoid precursor cells in the generative lymphoid organs, therefore in the thymus for T cells or bone marrow for B cells. Immune cells will either become immune competent or immune tolerant. The majority of T cell tolerance develops through central tolerance, as I said. In the development of T lymphocytes, they encounter a self-antigen at high concentrations. And if T lymphocytes respond too aggressively, they get eliminated in a process called negative selection, therefore leaving the T cells that minimally interact with self-antigens, creating self-tolerant T cells. Peripheral tolerance is essential because not all autoantigens are expressed in the thymus. Therefore, some self-reactive lymphocytes will escape their maturation center and require induction of tolerance in the periphery. Peripheral tolerance occurs when self-reactive lymphocytes encounter self-antigens outside of their maturation center. And the majority of B cells undergo peripheral tolerance. And as previously mentioned, there are 3 main mechanisms for which this takes place. First, peripheral tolerance through clonal deletion. It occurs when lymphocytes are activated by antigen-presenting cells, and this causes the lymphocytes to express IL-2 and IL-2 receptors. When activated with IL-2, the lymphocytes then express FAS and FAS ligand. When FAS and FAS ligand are expressed, these act as death receptors, and the ligation of these 2 molecules leads to the apoptosis of the lymphocyte through activation-induced cell death pathway. Anergy is the term used to describe functionally inactivated lymphocytes without cell death, and its key mechanism driving peripheral tolerance. Co-stimulation is important for activation of lymphocytes, and there are 3 different mechanisms that have been shown to induce anergy that rely on disruption of co-stimulatory activity. In the panel labeled A, appropriate co-stimulation from the APC to the lymphocyte with the interaction of CD80 and 86 and CD28 takes place. This leads to lymphocyte activation and proliferation. In the panel labeled B, you have a disruption of this CD28 and CD80-86 interaction, and anergy occurs. Panel labeled C shows that failure from the APC to actually express the CD80-86 also leads to disruption of this interaction and leads to anergy. And in the last panel labeled D, the lymphocyte actually upregulates the expression of CTLA4, which is a molecule expressed by the lymphocyte that interacts with greater affinity to CD80-86 compared to CD28, leading to disruption of the CD28, CD80-86 co-stimulatory signal and resulting in anergy. Immune regulation is the last mechanism of peripheral tolerance that I want to discuss, and it's achieved through the action of Treg cells. It's where peripheral tolerance becomes very complex and has been shown to occur through 2 main mechanisms in addition to a few others. Self-antigen specific CD4, CD25 positive T cells can directly suppress the activation of self-reactive T cells through cell-cell interaction. And anti-inflammatory cytokines such as IL-10 and TGF-beta are secreted by other immunoregulatory T cells, and they can also suppress the immune response. Moving on to tolerance and transplantation. This definition of tolerance is from Medawar, Billingham, and Brent, and they said that immune tolerance is a state of indifference or non-reactivity towards a substance that would normally be expected to excite an immunologic response. The quote in brackets, while maintaining a fully intact immune system, was added by the Immune Tolerance Network. The benefits of tolerance, as I've alluded to, are quite obvious. It allows withdrawal of immunosuppression, and it eliminates the chance for acute and chronic rejection, which will in essence eliminate the need for retransplantation. Tolerance was first shown by Owing in 1945, and he did this by demonstrating hematopoietic chimerism in dizygotic bovine twins. He showed that these cows, after birth, were tolerant to their twin skin transplant despite different major histocompatibility complexes because of their shared amniotic circulation. Following Owens, in 1953, Medawar won the Nobel Prize for showing how the immune system can be deliberately manipulated to become tolerant to a chosen antigen. They did this by demonstrating actively acquired immune tolerance through transplant of allogenic cells into fetal mice. They injected cells from mouse B into fetal mouse A, and then engrafted mouse B skin grafts onto mouse A, and they demonstrated that no rejection took place. These early studies laid the foundation for which tolerance is now being explored today. And there are many different strategies that exist. Inhibition of T cell response, manipulation of tolerogenic cells, inhibiting of B cell response. However, it's mixed chimerism, like in Medawar's mice and Owen's cows, where the most interesting results have occurred. Chimerism, from the Greek mythologic creature the chimera, is the concept that cells of different donor origins can coexist. And it's broken into mixed chimerism, where you have a variable number of donor cells, and full chimerism, where all blood cells are of donor origin. The initial studies on tolerance induction through chimerism required total marrow ablation. And given that transplant patients were undergoing a semi-elective procedure that already had good clinical outcomes with standard immune suppression, this was thought to be too risky. Sachs in 2011 showed that partial irradiation of recipients' bone marrow with peripheral lymphodeletion of recipient T cells allowed for tolerance to develop in non-human primate models. This required 1, non-myeloablative total body irradiation, 2, thymic irradiation, and 3, effective T cell depletion with ATG. On this graph, you can see some of their initial results. And there are actually 3 different populations that they looked at this in. The first had incomplete T cell rejection, or incomplete T cell depletion, and as such, all allografts rejected within the first 150 days. To accommodate for this, you can see their other cohorts added in splenectomy and cyclosporin A to complete T cell depletion to good success. And these results were built upon to move forward with clinical trials at a number of different institutions. Now, before I actually talk about the trials, let's just frame a few things. The most successful trials in tolerance utilize 1, a bone marrow transplant, and 2, a kidney transplant. And patients receive immune conditioning with T-cell depletion and total lymphoid irradiation. The MGH protocol is the oldest protocol that's in immune tolerance, and it was done based on their experience in mice models and non-human primates. Their first patient was a 55-year-old female with multiple myeloma and end-stage renal disease who was no longer tolerating her dialysis. She had a HLA identical sister who was willing to donate bone marrow and a kidney. The patient underwent T-cell depletion with cyclophosphamide 5 days prior to transplantation, equine ATG 2 days prior, and then total lymphoid irradiation 1 day prior. She was then continued on standard immunosuppression post-operatively. Her ATG was removed post-op day 30 and cyclosporin post-op day 60. Chimerism was tracked. And interestingly, actually, there was no evidence of hematopoietic chimerism at 5 months. This was confirmed with flow cytometry. But more than 12 years post-transplant, she still remains off immune suppression with a well-functioning graft and her multiple myeloma in remission. This protocol has been used in 6 other patients at Mass General. 6 patients were successfully weaned off immune suppression of the 7 total for a period of at least 3 years. 1 patient unfortunately experienced acute rejection, leading to recurrence of dialysis. 3 patients, including this first one, still remain off all immune suppression. 2 patients are on treatment for chronic graft versus host disease, but off traditional immune suppression. And 1 patient passed away from recurrence of their multiple myeloma. Given the success of the renal allografts in these HLA identical patients, MGH pursued this strategy with slight modification in HLA mismatched donor recipients. The HLA mismatch protocol is similar to the HLA identical protocol, but uses anti-CD2 antibody instead of ATG for stronger T-cell depletion. After the 3rd patient in this protocol, rituximab was added for increased T-cell depletion. 10 patients with mismatch for 1 HLA haplotype have undergone this protocol. Again, just living paired kidneys. Immune suppression was successfully withdrawn from 7 patients. However, for 3 of them, it was reinitiated at a time frame of 5 to 8 years. So they still received at least 5 to 8 years off immune suppression. 4 patients remain totally off immune suppression today, and 3 patients have had graft failures either from rejection or thrombotic microangiopathy. It's important to note that while this cohort achieved chimerism initially, it was actually transient in all patients. Following the success of MGH in their HLA mismatch protocol, Northwestern has also developed a protocol for HLA mismatch patients. The Northwestern protocol provides us with their largest data set. They've so far looked at 37 patients with HLA mismatch at 1 of 6 loci to up to 5 of 6 loci. And their protocol employed donor hematopoietic stem cell transplantation with a conditioning regime that included the infusion of a proprietary tolerogenic CD8 positive T-cell receptor facilitating cell to enhance hematopoietic stem cell engraftment, in addition to the usual T-cell depletion therapy, for which they used fludarabine, an antimetabolite, and cyclosporin A, and then obviously total lymphoid irradiation. They've actually been quite successful in weaning approximately 70% of patients off immune suppression after achieving persistent chimerism. And rather, in comparison to the transient chimerism achieved at MGH, at Northwestern, they've achieved near full chimerism in all of the patients they've weaned off immune suppression. Unlike the MGH protocol, though, Northwestern did not remove immune suppression unless chimerism had been achieved and sustained. It's interesting in these patients not weaned off immune suppression, though. Graft function has been maintained and has actually been shown as superior to their matched standard of care cohort patients. The negative of Northwestern's full chimerism approach, though, is that these high levels of chimerism have actually put patients at increased risk of graft versus host disease. There's actually been 1 fatal episode of graft versus host in this cohort. The Stanford protocol is the last protocol I'd like to discuss. It utilizes T-cell depletion with lymphoid irradiation and ATG. However, donors receive T-cell mobilization with GCSF prior to the pheresis. This helps mobilize CD34 positive and CD3 positive T cells. They've looked at 3 different cohorts. First, they have an HLA matched cohort, N equals 6. These patients received T-cell depletion with total lymphoid irradiation and ATG, and they received, cohort 1 is HLA mismatched, and they received a CD34 infusion without CD3 positive T cells. 2 of the 6 patients in this cohort were successfully withdrawn from immunosuppression after demonstrating mixed chimerism, but both patients required reinitiation of immunosuppression. The second group was their HLA matched cohort of 29 patients. These patients underwent a similar T-cell depletion protocol, but in addition to the CD34 positive T cells, they also had CD3 positive T cells. The thought process is that CD3 positive T cells allow better engraftment of the CD34, leading to a more persistent chimerism. Successful immune suppression drug withdrawal was achieved in 23 of the 29 HLA matched patients without subsequent rejection episodes, with a follow-up off drugs for anywhere from 24 to 157 months. The median, 80 months at the last time the data was updated. The last group was HLA haplotype matched of 22 patients. These patients also had T-cell depletion protocol and, similar to group 2, received CD3 positive in addition to their CD34 T cells. The amount of each of these was not fixed though. Rather, they had a dose escalation protocol based on the number of HLA mismatches. 10 patients in this group have achieved chimerism. However, none of the patients have been able to stay off immune suppression. So I've shown the 3 main tolerance protocols, which have had varying levels of success in HLA matched and HLA mismatched patients. And I think the next question is, could this be done at UBC? Could we establish a tolerance trial or join an existing trial? And for that, I think we should actually look at one other protocol, and that's UCLA's approach to tolerance. On a protocol basis, UCLA follows the Stanford approach with a small change of using plerixafor instead of GCSF, which allows for more rapid mobilization of T cells. The donor is able to receive just 1 dose of plerixafor prior to plasmapheresis versus multiple days of GCSF that are required in the Stanford protocol. At UCLA, they also use the CD3 positive T cells to aid with the CD34 positive engraftment. UCLA initially did a simultaneous kidney transplant and bone marrow transplant cohort of HLA identical patients, and encouraged by the success of this, they have since moved into retroactive implementation. They have an active trial in HLA identical recipients where tolerance is induced 3 months to 5 years post-transplant. They've done 3 patients so far, and one at just under 1 year and one at over 5 years. And the third patient they're currently seeing if there's chimerism going on. But this decoupling of the temporal relationship of kidney transplant to bone marrow transplant is beneficial for a few main reasons. First, there's a large amount of immunologic upheaval immediately post-transplant. A number of changes occur in the immune system between the addition of exogenous tissue, induction therapy, and the initiation of immunosuppression. And this delay allows the immune system time to stabilize. Secondly, and this is a critical point in a single payer system like ours, this decoupling allows flexibility in clinical appointments and treatment timelines. Patients can have their transplant, go home to fully recover. And while this recovery is ongoing, their donor can donate the CD3 positive and 34 positive T cells, which can be frozen until required. Then the recipient's lymphoid irradiation can be done after they've fully recovered from their surgery. And this can be done all on an outpatient basis. They could stay at home if they're local or in the kidney suites, which frees up hospital beds for patients who require acute care. And lastly, from a patient's perspective, patients waiting for transplant are anxious to get that organ. They want to get off dialysis, or they want to ensure they don't get started on dialysis. And so you don't delay transplantation with decoupling. And by decoupling these procedures, transplantation can occur, and then the pressure's off. The recipient and their donor can take time arranging the stem cell donation at a later date. So I hope the trial data I've shown has made you think maybe tolerance is possible. But to set up a UBC experiment, we would need to start slow. HLA identical patients and live donors. What about deceased donors though? HLA matched deceased donors are less than 1%. And if we can't match HLAs, there's something else we can match. And that's where epitope matching comes in. An epitope is a group of amino acids on the surface of a molecule that generates an antigenic response. Epitope matching is a precision medicine technique that's being developed in conjunction with UBC researchers. It's an in silico matching technique. As I said, HLA genes are the most polymorphic in the human genome, with over 25,000 alleles identified. The HLA proteins that these genes encode are the principal transplantation antigen. And what epitope matching does is, through next-gen sequencing, it looks at discrete structural eplets that are known to be drivers of the antibody-antigen response in HLA mismatched pairs. This simplifies the number of matches that are required and has been shown in simulations of target epitope matching at a high degree of overall compatibility, and actually perfect matching at clinically important HLA loci can be obtained. You can see in this pictogram how the number of class 1 and class 2 alleles is drastically reduced when you compare it to the number of meaningful eplets. So in closing, I just want to say that a tolerance program at UBC could be possible, but it would obviously be quite challenging. We could follow UCLA's retroactive tolerance protocol and start with HLA identical patients. Then, as shown at other centers, haplo-mismatched patients are feasible in a living donor population, and this could be combined with our epitope matching to improve chimerism and immune suppression withdrawal. And lastly, in a living program, moving into HLA mismatched and full epitope matched patients. I think the ultimate goal with transplant tolerance is to move into deceased donor matching, though, perhaps by the utilization of epitope matching. Whether or not this is possible, though, remains to be seen. Thank you.